Hello, everyone. This is Brad. Welcome to my presentation on ankle strains and sprains. Let me share my screen here. Okay, so ankle strains and sprains. So first off is a couple slides on the clinical presentation. So there are some risk factors that have been identified that may lead to an ankle injury. Some intrinsic risk factors are limited dorsiflexion, positive single leg balance test, or performance on a unilateral standing reach test, such as like a small excursion or line balance test. And then a positive single leg balance test may indicate reduced proprioception or deficiencies in postural control and balance, which may lead to an ankle injury. Other intrinsic risk factors include a low BMI and the female gender. Some extrinsic risk factors are participation in sports, volleyball, basketball, field sports, and climbing seem to be more highly associated with ankle strains and sprains. Such as high heels may lead to ankle injuries, and then males who participate in sports. Some more on the clinical presentation of ankle injuries are, so most of the ankle injuries happen to the lateral ankle. It's about 85%, which is from an article by Pilzer, which I'll be referencing more through the presentation. So since ankle injuries are more commonly at the lateral ankle, that's what my presentation will be focusing on. But a lot of this information can also be applied to ankle injuries in general. Two ligaments that are part of the lateral ankle complex are the anterior talofibular ligament and the calcaneofibular ligament, shown in the picture on the slide. So you might commonly see athletes presenting with lateral ankle strains in the clinic. This might be due to landing from a jump or stepping on someone's foot, and then the mechanism of injury, which is also shown in this picture. A strain or sprain happens with forefoot adduction, hindfoot internal rotation, ankle inversion and plantar flexion, external rotation of the leg. Overall, kind of that supinated foot again, which happens when an athlete like lands wrong on their foot or lands on someone else's foot. And then these are some signs and symptoms that the patient might present to the clinic with: pain, instability, swelling, crepitus, and weakness. So next up is how to diagnose, or the process of diagnosing a lateral ankle strain or sprain. So this recommendation says clinicians should use clinical findings of level of function, ligamentous laxity, hemorrhaging, point tenderness, total ankle motion, swelling, and pain to classify someone with acute ankle ligament strain or sprain. Level of function, we'll get to the future slides. This article didn't explain too much how to assess for hemorrhaging, point tenderness, total ankle motion, swelling, and pain, but I could imagine you could use like palpation, range of motion testing with a goniometer, circumferential measurements for swelling, and then any of the pain scales that we've learned to assess for pain. So with these measures, it kind of incorporates the ICF model with the physical impairments and then activity limitations and participation restrictions. So it's good to keep that ICF model in the back of our minds as we evaluate a patient who we're thinking an ankle strain or sprain. So I won't read them off, but there's a list of physical impairment measures to look at when examining this type of patient, and then some functional functional tests also to use when looking at this patient. So then these are some special tests for the ligaments. So ligament laxity was one thing to include when diagnosing someone with an ankle injury. There are plenty more that I've found in the research, but these are some of the more common ones that I saw: anterior drawer, anterolateral, and reverse anterolateral drawer, for mostly looking at ATFL strains, but can also be used for any lateral ligament injuries. The Talar tilt test, which is geared more towards the calcaneofibular ligament, and the anterolateral talar palpation, again for an ATFL strain. And then there's sensitivities and specificities are listed there. One thing with the talar tilt is that depending on how the therapist positions the patient's foot and what type of force they apply, they can test different ligaments. So it isn't just used for the calcaneofibular ligament, but when testing the lateral ankle complex, the talar tilt is used for the CML. But you can also do like a medial talar tilt to test for ligaments, like the deltoid ligament on the medial side. So then ligaments are graded. Let me see if I can move this. Ligaments are graded 1 through 3 based on how much function they have in their ankle, based on the results of those special tests that were just listed on the previous slide, and then based on those other factors like hemorrhaging, tenderness, total range of motion, swelling, and pain. So in terms of severity, grade 1 is the least severe, grade 3 is the most severe. Grade 3 can also be divided into A and B, depending on how much movement the clinician sees with the anterior drawer test. Yeah, those are the different grades of ankle strains and sprains. Okay, and then it is would also be good for a clinician to differentiate an ankle strain versus like a fracture or syndesmotic sprain or cuboid syndrome. So for a fracture, the Ottawa ankle rules are commonly used, which I'll elaborate on the coming slides. Syndesmotic sprain is diagnosis and grading of a syndesmosis sprain includes assessment of pain, extent of edema between the distal tibia and fibula, and posterior medial ankle regions. And then there are other tests that can be used to diagnose the syndesmotic sprain, such as the squeeze test, dorsiflexion compression test, and the external rotation test, which I'm not sure how those are performed, but if we were to look at syndesmotic sprains, we could look more into those tests. Cuboid syndrome often results in pain and localized swelling on the dorsolateral foot region adjacent to the cuboid. Those with cuboid syndrome may have limited weight variability and a positive mid-tarsal adduction test. So then to differentiate an ankle fracture versus just a sprain, these are the Ottawa ankle rules. So pain on the dorsal side of the medial and lateral malleoli, pain at the base of the fifth metatarsal, and pain upon palpation of the navicular bone. So the first bullet point there is to more looking at an ankle fracture, and then the second and third bullet points are more looking at a midfoot fracture, and then ability to walk at least 4 steps, either indicating ankle or midfoot fracture. And then also their sensitivities and specificity, along with their positive and negative likelihood ratios are listed. All right, moving into best practices management. The next few slides are recommendations that I've gathered from various clinical practice guidelines and systematic reviews at home to manage these types of injuries. The first thing that I looked at surgeries is necessary for these patients, or if it can be treated with conservative treatment. From what I gathered, conservative treatment is recommended over surgery because the results are comparable, and with surgery there's always risk of complications and it's more expensive. So to go with that conservative treatment, there's less complications, less expensive, so that's generally what's recommended. Although a couple things that one thing that I did find in a couple of articles was that the incidence of re-injury, of ankle re-injury is lower with surgical treatment compared to conservative treatment, which I think is an important factor to consider, because the re-injury of ankle or ankle re-injuries may lead to chronic ankle instability, which was addressed in the revision of the clinical practice guideline for ankle strains and sprains. I didn't include a lot of information about chronic ankle instability in my presentation, but that's the patient who it seems like they're always spraining or straining their ankle. So that might be surgical treatment might be taken more into consideration for those patients. Okay, and then the next thing I looked at in regards to best practice management is whether or not to immobilize. And generally what I found is that functional bracing should be used in short term. So this first recommendation is to use it for a maximum of 6 days. I'm sorry, a maximum of 10 days. Another recommendation said it can be used for up to a year, but generally a functional brace that still allows for functional movements, that doesn't completely immobilize the ankle, is recommended for treating pain or edema. This recommendation is in regards to stable ankle injuries. This would be the grade 1 out of these 3 grades that a few slides back. So using Price or protection ice compression elevation to early on in managing acute lateral ankle strains, those grade 1, so those stable ankle strains. And then these are more recommendations for the grade 2 and 3, which are categorized as unstable ankle sprains. Again, functional treatment should be used. Ankle braces can be used for the short term. Supervised rehabilitation, which in this article it seemed like mostly consisted of range of motion, gaining back range of motion, and proprioceptive training. Proprioception was mentioned a lot with chronic ankle instability, that people who may have chronic ankle instability have some reduced proprioception, leading to recurring injuries. So if there's using interventions to address reduced proprioception would be good to use for those patients, and for patients who just have an acute injury so that it doesn't turn into chronic ankle instability. Cryotherapy can be used, and along with we'll see on other side some other modalities to treat pain and swelling in that acute phase, so 3 to 5 days after the injury, and then NSAIDs can also be used for treating pain. So this slide is kind of what I have gathered from all these different articles that I looked at when treating ankle strains and sprains. So in general, conservative treatment is recommended as opposed to surgical, especially for grades 1 and 2. Modalities, except for ultrasound, can be used to reduce irritability. Medication can be used to reduce pain. Early weight bearing with some kind of short-term functional bracing, manual therapy, and then the patient can tolerate therapeutic exercise, progressing to occupation or sport-specific training that include things like balance, strengthening, neuromuscular rehab, and range of motion. Okay, and then this is an image. Sorry if it's a little blurry, that I got from the revised clinical practice guideline on ankle strains, and then the information that I have presented in these slides is focusing on this third area, the area with the yellow box around it. So the green is what clinicians should do. Yellow is it's okay for clinicians to use these, and then red is what clinicians should not use. So early weight bearing with support, so early weight bearing with some kind of bracing, therapeutic exercise, and manual therapy. And then a lot of those modalities is what's in that yellow box that clinicians can do. And then ultrasound is not recommended. And one article that mentioned ultrasound, why it's not recommended is that there are not enough studies that have shown a beneficial effect of ultrasound in the treatment of acute lateral ankle sprains, and even studies that do look at this as an intervention. There's not really consistent agreement on what parameters to use for therapeutic ultrasound and how to treat these. And then these are some outcome measures to use when treating ankle sprains and strains. The last one on here is the which is used to affect coping strategies for pain. Again, trying to prevent the development of chronic ankle instability. And then these are my references. All right. Thank you for listening.